Hello, everyone. Can you hear me?
Yes, we can hear you.
Okay. So good afternoon, everyone. For us, it's afternoon, or good morning, or good evening, depending on from where you're connecting. And my name is Giovanni Barbagli. I'm a research fellow at Banner in Phoenix with Dr. Baj. And today, we're going to talk a little bit about the treatment of the degenerative cervical myelopathy, in particular in the multi-level, in the setting of the multi-level pathology. So let me share my screen because I prepared a little presentation for you. Okay. Okay. So here we go. Okay. Okay, everyone can see my presentation? Okay. Okay, so start. And about today, I have nothing to disclose, and just as I said, a thank you to the organization of Virtual Spine for having me. It's a great honor actually, because I think I've been one of the first follower of the Virtual Spine and many years ago, and so that's, for me, it's truly an honor. Today, I divided our presentation like a sort of journey through the DCM, and I divided our journey in 4 different chapters. So the first chapter is going to be a very quick introduction on the pathology, an updated introduction on the pathology. The second chapter is going to be a case series from my previous hospital, because before coming here, I work in Italy as resident and as an attending, and I will present you our case series from my hospital when I was a resident about the treatment of the DCM, or the multi-level DCM. The third chapter will be a very quick review of the most updated literature. I just picked up a few papers published in between 2022 and 2023. And the final chapter is going to be a brief discussion on some clinical cases. I will show you some pre-op and post-op of our cases, so we can discuss together, and we're going to have the conclusion of our day together. So while we're talking about DCM, the degenerative cervical myelopathy is probably the most common cause of spinal cord dysfunction, and it's reported to be to have very high incidence of hospitalization, because if you think that in North America the number of patients hospitalized for some clinical presentation of the DCM is around 8 per 100 K on population, and it's a very high, actually it's a very high number. Another important topic about the DCM is the diagnosis of it, because if you think that a lot of pathology have signs and symptoms that overlap with the DCM, just think about the diabetic neuropathy, which can present with a very similar paresthesia to the DCM. The AO Spine and the University of Cambridge, they are developing this project called Recall DCM with the aim to understand if there are some criteria, precise criteria to diagnose the DCM, because it's not only important to diagnose the DCM, but the precise diagnostic of the DCM can lead to a better treatment of it. So the cervical myelopathy is historically considered a result of both so-called dynamic and static mechanical factors, with the static mechanical factors are like the hypertrophy or the ossification of the posterior longitudinal ligament, the ossification of the ligamentum flavum, that can cause the compression, the narrowing of the spinal cord or the spinal canal, and the compression of the spinal cord. The dynamic factors, which are barrel deflection and extension of the neck, that normally happens during our day life, in case of degenerative cord, like with hypertrophy or ossification of the ligaments and all the modification that we said, can cause a sort of continuous traumatic injury against deflection against the osteophytes, for example, from the posterior part of the vertebral body, and the extension against the ossification of the ligamentum flavum. So this kind of continuous, with flexing extension, continuous traumatic injuries can lead to degeneration of the neural structure and to the myelopathy. In the last 10 years also, the scientific community focused its attention also on a third player, which are the so-called biomolecular factors. Because just think what we said before, the continuous flexion extension in a spinal cord that is already damaged and that is suffering from a spondylotic degenerative disease can lead to an incipit of phlogistic process, like inflammation processes, that can lead to the disruption of the blood-spinal cord barrier and the disruption of the endothelial cells. And all of these processes actually will lead eventually to chronic damage, a chronic inflammation. And the chronic inflammation, along with the dynamic factors, along with the ossification of the ligaments and the osteophytes, lead to a chronic and irreversible myelopathy. So that's how the degenerative spondylotic myelopathy works. After this introduction, let me introduce our clinical series. So we retrospectively review 302 patients from our records in between 2020, 2014, 2019, just picking up patients that they've been operated for a cervical procedure for non-traumatic reason. So we divided this patient in two big groups: the patient that underwent an anterior surgery, and the patient underwent anterior posterior surgery. So, of course, our aim was to analyze the effect and the outcomes of the both anterior and posterior procedures in the setting of cervical myelopathy, only for 3 or more levels. So, using this criteria of exclusion or inclusion, depending on from where you see it, we just found, and it's like normal, 10 cases operated for posterior multi-level surgery and 15 cases for the anterior surgery. Actually, at the very beginning, we found a little bit more. The initial population was not 25, but 35, but we had to remove some because 5 actually passed away during the follow-up, and the other 5 got rheumatoid arthritis as primary diagnosis, and we exclude them. So this population belonged only on patients that underwent a laminectomy infusion or an CDF, that's suffering from myelopathy or myeloradiculopathy, from a degenerative disease, and that got and we call it adequate follow-up, which means at least 1 year of follow-up. But why we did so? We did so because, historically, it's considered that the anterior surgery, a CDF in particular, is more suitable for the diseases that affect only 1 or maximum 2 levels, while the posterior is frequently chosen as a procedure for 2 levels or more of disease. Well, the rationale behind this is that the longer the number of levels you have to approach through the anterior surgery, the higher the chance to get some damage in structure like the recurrent laryngeal nerve. And that's why it's considered that below 2 levels ACDF or anterior procedure and over 2 levels posterior procedure. Actually, if you do a review of the literature, the strength of the evidence is not that big, and there's not a clear superiority of one surgery on the other when we talk about the multi-level disease, so more than equal or more than 3 levels. So this is the data that we're starting from. So as you can see, there were no statistical differences in between age, gender, and number of levels in between the 2 groups, anterior and posterior. And you can notice that the anterior group of patients got an MDI score a little bit higher in the preoperative setting rather than the posterior, while the posterior got a NURIC score a little bit higher. And that is probably due to the fact that in our series, the posterior patient got a higher, a more severe myelopathy. That's why probably the NURIC score is higher in the posterior group rather than the anterior. So we analyzed our clinical series and we started to have a look on the complications. But not surprisingly, we got a higher number of respiratory complications in the anterior group, in particular respiratory distress and some kind of difficulties in weaning the patient off the tube. One patient actually needed blood transfusion for massive blood loss, and again, not surprisingly, you can see how the number of complications, dysphonia and dysphagia, were higher in the anterior group. Once again, that's not surprise. We cannot be surprised about that because you know, the anterior approach itself could cause these complications. But let me tell you, both dysphonia and dysphagia, even if higher in the anterior group, were temporary, so not permanent. And if I remember well, after 3 months, they were completely disappeared in all patients. We also stratify this complication as categorical variables, and we use the Fisher-Exit test to understand if the difference in between the complication rate was statistically significant, and was statistically significant. So in our series, in our hands, the anterior approach got more complications, and this have a statistical significance. Other important result was the difference in between the surgical time. So once again, in the surgical time was way longer in our series in the anterior group if compared to the posterior group. And as you can see from the p-value, this result was highly statistically significant, and I think the 2 results that we have just seen, the longer surgical time and the higher number of complications, regardless of the kind of complication, I think there are these 2 data are connected, because of course the longer the surgical time, especially in the anterior group, the longer the retraction that you have on your structures inside the neck. And that's probably why the rate of complication is higher in the anterior group compared to the posterior group. If we have a look to the clinical outcomes, we can see that both anterior and posterior surgeries, they allow us to get a very good, or at least an improvement in both NDI and Nuric scores. However, there's no great differences in between the anterior and the posterior group. So the improvement in between the two has no statistical significance. What I want to show you here is how the Nuric variation, which is, as you remember, the grade of myelopathy, actually is greater in the posterior group compared to the anterior group, and that's important. We will come back on this result after, and we will talk about it. If we see instead of doing an intergroup analysis, an intragroup analysis, we will see how the variation in both NDI and Nuric have a high statistical significance in the anterior group. In the anterior group. So that means that the anterior surgery is quite effective in achieving both NDI and Nuric improvement. So that's something that it's a sort of paradox, no? Because we just said that the improvement in the Nuric score for the posterior pathology is better, but has no statistical significance. How is it possible? It's possible because the problem on our posterior group is probably the number. It's too little, and that's the reason of our apparently paradoxical result. Okay, and you can see the Nuric variation in the anterior group. What was interesting is when we compared the variation of the NDI with the age of our patient. Even though this result didn't get statistical significance, we can see a trend. The higher the age of the patient, the less you can have the improvement. So that means the older the patient, the less are the expectation on the results in terms of NDI variation, at least in our series. We also evaluate our results not only on clinical aspect but also on the radiological aspect, and we take in consideration the S2, S7 SPA, the Cobb angle, and the so-called Jackson physiological stress line. I mean, those are normal parameters that I think we should evaluate every time when we do surgery in this setting, because as what happens in the lumbar spine, it's very hard to plan, especially multi-level surgeries, without taking in consideration the sagittal and sometimes the coronal parameters. And if you look to our results in that matter, we can see how actually, and we're talking about something that has a very strong statistical significance with a proper follow-up, because follow-up was more than a year for both of the series. The postoperative cervical lordosis measured either with Cobb angle or Jackson angle is higher in the anterior group. Once again, this result is not something that surprises us, because it's widely accepted that if your aim is to get a proper lordosis along with other results in certain kind of surgery and cervical surgery, the anterior approaches generally are the one preferred. So once again, not surprisingly. If you look to the result about the C2, C7 SVA, there is no statistical differences in the result of the two series. But the C2, C7 SVA could be also analyzed with the age of the patient. So using once again the Spearman method, which confront two variables and the relationship with two variables, we can see that the higher the age of the patient, the greater the C2, C7 SVA. And that got a statistical significance. So what does it mean? Look, we are still working on our results. So these are preliminary results, but we can already say something out of these results. So first of all, if you look to the raw data, the NDI and the numeric variation seems to be in favor of the anterior approach. But we have to remember two things. First, in our series, the disease, the myelopathy, was more severe in the posterior group. And the differences that we just shown have no statistical significance. So the reason why the raw data show this is because, you know, the anterior approach has not all the disruption of the posterior muscles that is typical of the midline incision approach. And this is probably why the NDI, the raw data of the NDI score, post-operative score is better in the anterior approach rather than in the posterior one. And probably the better outcome in the numeric score is given by the direct release that you do of the anterior horn when you operate from the anterior. The second result is that the anterior approach is apparently associated to a high number of complications. But I mean, that's something that comes along with the anterior approach. I mean, if you pass from the anterior, those are the structures that you have to deal with. So it's hard to not have a higher number of like dysphagia or dysphonia with the anterior approach, because, you know, from the posterior it's impossible. And another thing that is important, sometimes as we know, the cages of the ACDF, they can mobilize. So that's something else that could make the rate of overall complication of any anterior series worse than the posterior. And the third result is that the older the patient at the time of surgery, the worse the clinical outcome. Once again, that's something that's kind of normal because, you know, the older you get, the higher the number of comorbidities from anywhere, like cardiac, pulmonary, everywhere. And also, when you know the age advance goes, you will be less able to repair the damage in your body. And, you know, this is something connected to any elderly. It's not just the elderly that got the myelopathy. So that's for all. You have any questions so far on our clinical series? Okay, so if not, we can just go to our chapter 3. So maybe you don't know, but since I've been like 15, I practice martial arts, and the martial art that I practice is the kendo, which is the samurai martial arts. So in kendo, you fight against each other, and there's a referee that decides who strike the winning technique. And there are two colors, the red and the white. And the results are only 3. You can win, you can lose, or you can make a draw. Okay, that will be useful because now we're gonna through a bunch of papers, and we're gonna see who is going to win according to these papers in between the anterior and the posterior approaches. So starting from this very interesting paper made by a Canadian group, in which they compare the multi-level approaches for cervical degenerative cervical myelopathy using a tool called propensity score match. The propensity score match is a statistical tool that help to evaluate not randomized big data, especially for cohort retrospective studies. So if you look to this table, it's pretty clear how the rate of complication and the hospital stay is quite in favor of the anterior group, because the posterior is associated to a higher rate of postoperative complication and with a longer hospital length of stay. In this series, in this study, like to our study, the incidence of the complications such like horse's nest, dysphagia is lower in the posterior group. So what about this paper? So according to these authors, here we have our red and white table. If we score, like if we assign points, I mean, we should call it a draw, and that's how the authors conclude their paper. So for them, there's no superiority of one technique on the other. This is another interesting study that was published 1 year ago in the North American Spine Society Journal, and here the authors compare specifically a series of 4-level surgeries, either anterior and posterior. So they focus their attention especially on the rate of the adverse event, calling serious adverse event complications such as pulmonary embolism, deep venous thrombosis, sepsis, while they call minor adverse event complications such as acute kidney injury, hematoma, and hemorrhages that are not giving shock, wound infections. And as you can see from the forest plot here on the right of the screen, the rate of adverse event, either serious or minor, is quite in favor of the anterior approach. The only complication that was like inferior in the posterior approach is the dysphagia. However, these authors also study, yeah, that's what we just said. The authors also study their data with the Kaplan-Meier curve, which is a survival analysis along five years. And if you look to the curve, it's clear how the rate of reoperation in 5 years is way higher in the anterior group if compared to the posterior group. So once again, if we try to assign 1 point to one technique or to the other, once again we should call it a draw. So far that's it. Recently, a few months ago, someone published a paper where the anterior and posterior approaches for the multi-level DCM were analyzed looking at the PROs, so the so-called patient-reported outcomes. And if you look to the complication rates and readmission rates and the revision surgery in this paper, there's no great differences in between the two techniques. something different if you look to the preoperative parameters of both series, because you can see the C2, C7 preoperative lordosis and kyphosis was much more higher in the anterior group. But once again, that's not surprise, because generally, if you want to get a proper lordosis among the other results, the anterior approach generally is considered the one that you need. So they also evaluate the PRS about the clinical outcomes, and well, it's true that the patient underwent ACDF. They develop a less postoperative pain and less postoperative neck disability, and you can see from the numbers that these results have important statistical significance. But if you see to the delta, so the variation of the NDI in between pre-op and post-op, and you compare them with the with anterior and posterior technique, and these results are not that evident, and there's no clear superior of one technique on the other, even if you analyze the MJOA, which is another grading score for myelopathy in the cervical degenerative disease. So once again, if we try to do a sort of comparison, we should, even though the variation in the NDI is higher in the anterior group, the authors conclude that both techniques have similar outcomes. So even in literature, here we can call it a draw. Okay, any questions so far? Otherwise, we can start the most fun part of our day together. So this is the first case. Let me show you the CT scan. Okay. Okay, so that's the CT scan. That's the MRI. Okay, so this is a 64 years old man which was working as a lift worker with a 6-month history of progressive disease and especially a wide bias gait with the Hoffman sign positive, and the NDI score of 39 and the Nuremberg score of 4 with no signs of radiculopathy. So what about your options? From anterior, if so, what? ACDF, corpectomy for posterior, or you prefer to refer the patient to someone else? Let's guess. I mean, it's just, you know, maybe we took the wrong decision. It's not, I will show you what we did, but probably it's not the right choice. I don't know. What do you think? If you need to see again, like MRI or CT scan, just tell me. I can show you. Okay, no one wants to try to do something to this poor patient. Maybe you want to refer to someone else, which is something that you can do. Okay, let me show you what we did. So at the moment, our choice was for a posterior approach. Posterior approach because at the time, we think that we could get better decompression from posterior. And let me tell you, the radiological results are not that bad. We could have done better, but I mean, we were quite satisfied. And the patient now is, if I remember well, 3 years out of surgery, and is doing pretty good. And he came back to work, not as a lift worker, of course. Now he's working in the office, but still, I'd say that's a good result. Okay, so let's start with the case number 2. So here is the CT scan. So as you can see, all of our patients here treated with a multi-level disease, they got not only myelopathy, but an advanced cervical spondylotic changes. Because as you can see from here, I mean, it's quite impressive. Okay, so that's the CT scan, and that's the MRI. And MRI is quite clear as well. Yes. So you can see here the compression is it's something. And this patient was coming. He was like a retired CEO with a 1-year-long history of progressive strength deficit at both arms, especially on the right arm, with a deep tendon hyperreflexia and a positive Hoffman. Both the NDI and the NURIC weren't that bad, but the guy was quite annoyed about his condition. So once again, someone want to share with us his decision or her decision from anterior, from posterior, and from anterior what? A CDF, corpectomy. Okay, a CDF, one CDF. And once again, this is the CT scan. Okay, so a CDF. Okay, so thank you for sharing with me. And let me tell you that for this case, we agree, because we did an CDF as well, a 3-level CDF, and the results were pretty good. Once again, the cervical lordosis was pretty good, and the patient got a very good recovery. Actually, I remember him well because he was a funny guy, and he was one of the best that recovered from surgery. So we were quite happy, and I called him before coming here in the US 3 months ago, and he's still fine. So he's still working, even as retired CEO, he's still doing some job, and is enjoying his boat. So kind of happy. And the third case, yes, this flexion, and this is the extension. So the third case, let me show you. We have, if you remember, just the MRI. So once again, kind of degenerative myelopathy with inversion of the cervical lordosis. If you can see here, we have a complete loss of the cervical lordosis with kyphosis, actually. And that's the axial scan. That's the same MRI, made the same day. Okay. Oh no, we have the CT scan here. Okay, and that's a CT scan. And once again, osteophytes, ossifications, kyphosis. See here the osteophytes in between 4 and 5 in particular. So this man was jet pilot, actually, that when came to us, he was working with important private company, and with a 2-year history, very long actually, of numbness at both arms, and onset, like if I remember well, 4 months before, of strength deficit, which was something, especially on the right arm. He got positive Hoffman and a very important neck pain with the NDI of 35 and the Nuric of 2. So once again, the questions are the same. What we do here, anterior approach, posterior approach, if anterior, which kind of anterior approach, or we can just refer to someone else. Let me show you again the MRI. Okay, a CDF. Okay, kind of high number of the CDF here. Okay. And well, let me tell you once again, we agree because we did a 4-level ACDF with a decent recovery of cervical lordosis. And the patient, even though at the very beginning it didn't improve that much, at the long follow-up, after 2 years, he was fine. He came back to work. He's still a pilot, so he's quite happy. And I think at the end of the day, that's a pretty good result. So we have here another interesting case. That's the CT scan, and once again you can see the degeneration, the high level of degeneration of this neck, and that's the MRI with an important sign of myelopathy. Let me show you again. That's the MRI. And the patient was a woman, a civil engineer, with a 2-year history of unstable gait. But the thing that she was worried most was that she wasn't able to play tennis anymore, which was apparently her favorite sport. So she got a positive Hoffman and an NDI, like right after, in the grading score of the severe NDI 27, and a Nuric of 3, because she was badly bedridden. So yes, thank you. Once again, we have our 4 choices. Look, I'm showing these choices not for fun, but because these were the choices that we had at the time. This is something that in the hospital that I come from, in Florence, you can see the green symbol. It's something that we do for any case of multi-level cervical myelopathy. We don't have an answer, a quick, immediate answer. Every time we ask ourselves which one of these 4 options we get. So here we have, okay. Ooh. So a lot of posterior approaches here. So you're gonna be okay. You're gonna be happy about that because we choose the same. We choose the same, and with the 3-level decompression infusion from posterior. And she recovered well, and she came back to play tennis. And she texted me actually 1 year ago with a picture of her playing tennis. So she was very very happy. So last case, and here the post-op CT scan. Yeah, that's, yeah, I remember. I remember this case. That was here. You can see here that was my fault. I wasn't able to get the screw inside this lateral mass. And once again, the radiological results are pretty decent. You can do every time something better, but we were happy. So go to the last case, case number 5. So once again, myelopathy, cervical spondylopathy, an inversion of the lordosis with a kyphosis. So I'd say not a very good preoperative start. And as you can see, this patient, 58-year-old male, got one of the worst risk factors ever. He is a lawyer, and he was coming to us with an 8-month history of unstable gait and referring some difficulties in writing with the hand, both actually left and right. He got an hyperreflection and a pretty bad neck pain, you can see from the NDI of 29, and an URIC score of 2. So once again, want to remind you the risk factor. Once again, what's our choices? Let me show you the MRI again. So someone want to tell me what's the best approach for this guy? ACDF. Okay, someone say CDF. I just want to show you again. Yeah, actually, ACDF seems a pretty smart choice, especially because of the kyphosis of the patient. So that actually that it's a good point. It's a good point, and let me tell you, that's exactly what we did. We did a 3-level anterior cervical compression infusion, and the results were once again decent, not good, because you can see from the cervical parameters weren't that good, and honestly, the patient didn't recover that well. This is one of the reasons why we followed him quite strictly in the follow-up, because you can see here, yeah, sorry, that's same. Inflection and extension. This is the difference in between. Sorry. Let me come back to our case 5, because I want to show you. I want to show you something that's particularly important for this case. Okay, here we go. So that's the postoperative X-ray, okay? So apart from the cervical parameters that were, I mean, not perfect, there's nothing here, there's nothing yet. The spinal cord is in bad shape pre-op, very bad actually. And that's probably why he didn't recover that well. But the thing is, apart from this, and apart from the immediate postoperative cervical parameters, this X-ray was made like 1 week after surgery. Instead, this one was made 3 months later. So someone could tell me what is going on here, because I think it's something that, I mean, retrospectively analyzing the patient, I could see it. At the very beginning, when the patient came with this X-ray, I wasn't able to see what was going on here. But you will see later. Someone has some clue. But this is, once again, this is the 3 months follow-up X-ray. At the time, the patient was like at home. and not working and not bad rhythm, but still like at home doing nothing. Let me show you the flexion extension. So that's the flexion, and there's the extension. Some clue? Okay. That's the MRI, 6 months after surgery. So, what happened? I mean, it's with the MRI. I just hope that we did it. That we would have done it before. With the MRI, it's pretty clear that just above the hardware, something happened, and you know. Yes. Well, at the time, what we thought was the patient got an ASD, agent segment disease, at this level, and that's why after like months of thinking of what we could have done, we decided to reoperate him from posterior instead of from anterior. To decompress from posterior C3, C4. Well, as you can see, the cervical parameters didn't improve that much. But after the surgery, the patient got some improvement. And now he's able to write short sentences with his hands. And I cannot say he's happy, but still is not unhappy, which is, you know, he's a lawyer, so that's something we are happy of. Okay, so what messages we can just bring home from this hour together? I thought a lot about what kind of messages I could share with you in terms of what is best for a for a cervical myelopathy, a multi-level cervical myelopathy. So what I decide is to show a sort of flow chart that me and my hospital we did for this pathology. So let me tell you. Okay. So that's how we work. So if we have a patient with a symptomatic multi-level cervical myelopathy from a degenerative disease and has to be symptomatic, okay? If the levels are 5, there's no discussion. We just go from posterior, okay? I'd say 99% of the time. If we have a 3 or 4 levels, the first question that we try to answer is, the patient got some anterior neck comorbidity, like previous thyroid surgery or neck irradiation for any reason? If yes, we just go from posterior, because that actually effect of experience, because we operated one patient once from anterior, from a multi-level DCM, 4 levels. And the patient got 1 year before radiation for cervical cancer. And let me tell you, wasn't pleasant. The anterior approach was so hard. And actually we got a perforation of the esophagus. So, you know, from that time we said, no way, just go from posterior. So if your patient have no neck comorbidity, the next question is the deformity connected to the condition, is that severe? If so, for us, it's all a matter of one or the other. We go 360 degrees. If the deformity is not that much, the other question that we ask ourselves is, do we need lordosis? If we do, we go for anterior. If we not, we go from posterior. But if we go from anterior in a patient with no neck comorbidities, with no excessive deformity, but that need regaining of lordosis, the question that we ask ourselves is there any ossification of the posterior longitudinal ligament? Because if so, if there is, we're gonna do a corpectomy. If not, we're gonna do an ACDF. Just because with the corpectomy, we feel that the removal of the ossified ligament could be easier, where generally it's not that easy. So okay, we are done. Thank you all. I want to thank you also my previous team in Florence for our years together and for allowing me to share our previous results. So I think we can just stop sharing. Okay. Okay, so some questions here. Comparative studies assume clinical equipoise between anterior and posterior groups. In your opinion, is there a Cobb angle kyphosis cut off when posterior only surgery should be not attempted? That's a very good question, actually. I don't have precise number. I mean, minor than this have to do anterior, or major than this have to do posterior. Actually not. The thing that guided us so far was, as you can have seen from the series, if the patient got just a less lordosis of than expected, we just go from anterior, because in our hands the anterior approaches allow you to get more lordosis. But no, we don't have a cutoff actually for both Cobb angle or Jackson or any other kind of measurements you want to do for a lordosis. Our first thing was, and still is, how we can get best clinical outcomes rather than radiological. Even though radiological outcomes are important, sagittal parameters are important, the first thing is, which is the approach that, to us, get the best outcome, clinical outcome. There are some situations in which the deformity itself is something that could give it to a patient a sort of worse clinical picture. In that case, if when the deformity is part of the disease, we go 360 degrees. That's something that I didn't mention a lot, but one of the reasons why from 302 patients of our original selection, we selected only 25, because were 25 that went only anterior or posterior, is because in our series we actually we perform a lot of 360 degrees surgery. And probably that's why I have no precise answer for that question, because we perform a lot of circumferential fusions. Okay, so that's it. I think if there are no other questions, we could call it a day. Okay, so thank you everyone. Thank you for allowing me, and okay.